Hello guys, we'll be discussing Parapharyngeal Space Tumors today. I'm Dr. Ankit Vishwani, your faculty for head and surgery entrance. So, Parapharyngeal Space Tumors is a very important topic for exam, as it is a highly, personally I like this topic very much. It's a highly conceptual thing, and if you listen to the talk carefully, I don't think there will be any problem in understanding the topic. So starting with the topic, what are the boundaries of the parapharyngeal space, and by what other names the examiner can confuse you? So first you should know the other names for parapharyngeal space. The other names are, it's also called as pterygomaxillary space or pharyngomaxillary space or a lateral pharyngeal space. And for the boundaries of parapharyngeal space, you can imagine that you can see my face and imagine that the space is between the mandible laterally and the tonsil medially. So the lateral boundary is the mandible and medial boundary is the tonsil. So here it is the inverted pyramid. Here it is here you can see it is an inverted pyramid where superior boundary is the skull base, medial boundary is the oropharynx and the nasopharynx. Lateral boundary, medial boundary, as I told, is the oropharynx, that is, tonsil is a part of oropharynx, so it's the medial boundary and the nasopharynx. Lateral boundary is the mandible, the parotid deep lobe, the ramus of mandible, etc. Anterior boundary is the pterygomandibular raphe, and posterior boundary is obviously the prevertebral muscles and the cervical vertebrae. Superiorly it is skull base, and inferiorly it is the hyoid bone. So as I told, it's a inverted pyramid with base towards the skull base and apex towards the hyoid bone. Now recently, since the approaches of parapharyngeal space tumors have come up, like transoral robotic approach or endoscopic approaches have also come up. The classical approach always is transcervical or transmandibular, but since newer approaches are coming up, there has been a newer classification of parapharyngeal space. It is now divided into three parts, that is the upper parapharyngeal space, middle parapharyngeal space, and the lower parapharyngeal space. So how are the boundaries decided? That is, if you go from the skull base to the lateral pterygoid, it is the upper parapharyngeal space. And if you go from lateral pterygoid muscle to the medial pterygoid, it is the middle parapharyngeal space. And from medial pterygoid to the hyoid bone is the lower parapharyngeal space. So why I am telling this upper, middle and lower parapharyngeal space, its relevance will come in the end when I will be teaching the recent advances in approaches to the parapharyngeal space tumors. Now, as we are discussing parapharyngeal space, I would quickly like to tell you about some few head and neck spaces, important head and neck spaces. Though it will be a separate class. It's an important topic and it will be a separate class. But quickly we'll go through the other head and neck spaces. Number one is the parotid space, which lies between the superficial and the deep cervical fascia. So the parotid is encased between these two fascia. So any swelling of the parotid causes deep is highly painful because of the stretch. So this is parotid is between superficial and deep cervical fascia. Peritonsillar space is between the superior constrictor and the capsule of the tonsil. Now, important space is the retropharyngeal space, which lies between the buccopharyngeal fascia anteriorly and the alar fascia posteriorly. And this space extends from the base of skull to the bifurcation of trachea, that is T4. And it is divided into two compartments by a midline fibrous raphe. And each compartment is called a space of Gillett. So the importance is that the retropharyngeal space will always extend. Any abscess will go from the base of skull to the T4, any abscess of retropharyngeal space, and it will be there always be a unilateral bulge because it is separated by a fibrous raphe. So it will be always a unilateral swelling. Now, second is a danger space. It is I have not heard of any abscess in this area. Just for exam point of view, just remember this space, that it is just behind the retropharyngeal space. So the boundaries are the anteriorly alar fascia, and the boundaries are anteriorly alar fascia and posteriorly the prevertebral fascia, and it extends from the base of skull to the diaphragm. And just behind this space is the prevertebral space, which lies between the prevertebral fascia and the bone, and it extends from the base of skull to the coccyx. And since there is no fibrous raphe here, any swelling of the prevertebral area, that is any prevertebral abscess, will present as a bilateral bulge as compared to the retropharyngeal abscess, which will present as a unilateral bulge. Now, this is just an axial section showing the head and neck spaces. So this one was a sagittal section. This is the axial section. So this is the retropharyngeal space between the buccopharyngeal fascia and the alar fascia, and just behind it will be the danger space between the alar and the prevertebral fascia, and just behind it between the prevertebral fascia and the vertebral there will be prevertebral space. This is the parotid space. Medial to this is the carotid space, and this space which is not colored is the parapharyngeal space. So this axial section is the most important cut that the radiologist looks to decide what kind of a parapharyngeal space tumor is it, depending on the displacement of the parapharyngeal fat and the displacement of the great vessels in the carotid space. The diagnosis of a parapharyngeal space tumor is made. So this axial cut is important. That's why I've kept this slide. Now coming to the parapharyngeal space tumors proper. So from now, the next 3-4 slides are definite exam questions. So number one question is, how is the parapharyngeal space divided? Parapharyngeal space is divided by the styloid process. The styloid process divides the parapharyngeal space into an anterior compartment called as pre-styloid compartment and a posterior compartment called as post-styloid compartment. Now the major content of the pre-styloid compartment you should remember. So if you know the contents, you will know the pathologies arising from each compartment. So therefore, learning the content of each compartment is important. So first, content of the pre-styloid portion of the parapharyngeal space, that is the pre-styloid compartment of the parapharyngeal space. The first content is the deep lobe of parotid. So any swelling arises from the deep lobe of parotid. Any tumor of the deep lobe of parotid is a pre-styloid parapharyngeal space tumor. Number one. Number two, there are small minor salivary glands. I should remind you that parotid is a major salivary gland. So there are small minor salivary glands from also in the pre-styloid space. So any tumor can arise from these minor salivary glands and cause a pre-styloid parapharyngeal space tumor. And then there is the ascending pharyngeal artery in the pre-styloid space that you can just remember. So two major contents to be remembered are the deep lobe of parotid and minor salivary glands. Now in the post-styloid compartment, post-styloid compartment is a posterior compartment and is also called as a neurovascular compartment because it has major neurovascular structures like the carotid artery, the jugular vein, 9th, 10th, 11th, 12th nerve, sympathetic chain, and other glomus bodies and all. So 3 or 4 important differential diagnoses of the pathologies that are arising in the post-styloid compartment of the parapharyngeal space are: number 1, carotid body tumor; number 2, any tumor arising from the vagus nerve like a schwannoma, a neurofibroma, or any glomus tumor of the vagus, that is glomus jugulae. So these, or any sympathetic trunk tumor. So these are the 5 DDs of post-styloid parapharyngeal space tumors. That is, number 1, carotid body tumor; number 2, this is to tell you, this is vagus nerve, this is IJV, this is carotid. So number 1 is a carotid body tumor; number 2, a glomus vagale, or a neurofibroma, or a schwannoma arising from the vagus nerve, or a sympathetic body tumor. These are post-styloid tumors. So now quickly classifying these tumors, there was a systemic review. This is a highly quoted study by Farooq Rifa et al. There was a systemic review and meta-analysis by Farooq Rifa, which tells that the parapharyngeal space tumors are 80% of them are benign and only 20% of them are malignant. And out of these 80%, 60% are pre-styloid. Out of these 80% benign lesions, 60% are pre-styloid and only 20% are post-styloid. So majority of the pathologies you will be seeing will be pre-styloid. And among the pre-styloid, the most common tumor is the pleomorphic adenoma, which arises from the deep lobe of parotid. So if you encounter a pre-styloid tumor in your life in a patient, it will be most likely a pleomorphic adenoma arising from deep lobe of parotid. This is the highest probability. Now, post-styloid tumors are paragangliomas. We'll be discussing paragangliomas. Number 2, schwannomas. Number 3, neurofibromas. or they can be mets to parapharyngeal space, like from thyroid, from any hematological malignancy, or from nasopharyngeal malignancies. They can be mets to parapharyngeal spaces. So what are the post-styloid tumors? I told number one is DD is the paraganglioma. So carotid body tumor is the most common paraganglioma, which is present in post-styloid space. Number two is the Glomus vagale. So among this, Glomus vagale has the highest chances of malignancy. Then there can be a schwannoma rising from the vagus nerve, or there can be a neurofibroma. Just telling that, just you should know that these paragangliomas are highly vascular tumors as compared to schwannoma or neurofibroma. So we discussed the various pathologies in the pre-styloid and post-styloid area of the parapharyngeal space. Now coming to how to reach a diagnosis of what tumor, which is the tumor that is there in the parapharyngeal space, what tumor we are dealing with, how to reach a diagnosis. So first, you as a clinician, you should see the clinical features the patient is presenting to you with. So suppose it's an anterior swelling of pre-styloid compartment swelling. The number one clinical feature will be prolapse of the tonsil. Also, there can be an external swelling behind angle of jaw. So if there is prolapse of tonsil with external swelling behind the angle of jaw, your differential diagnosis is a pre-styloid tumor. Now, if it is a post-styloid tumor, then instead of causing a bulge in the tonsil or the prolapse in the tonsil, there will be a bulge in the pharynx behind the posterior pillar. So this is a clinching thing. This is a clinching clinical finding differentiating between a pre-styloid tumor, which causes a prolapse of tonsil, and a post-styloid tumor, which causes a bulge in the pharynx behind the posterior pillar. And also there can be paralysis of 9, 10, 11, 12 nerve, which are the neurovascular bundle associated with the post-styloid compartment, as I already told, or there can be a paralysis of the sympathetic chain. So this is a clinical diagram showing a bulge in the tonsillar pillar. So clinching a diagnosis towards a pre-styloid parapharyngeal space tumor. If the bulge would have been posteriorly behind in the posterior pharyngeal wall or behind the tonsillar pillar, behind the uvula, we could have thought it as a post-styloid. Now, this was all about clinics. Now, but you should know that the final confirmation of a parapharyngeal space tumor or a parapharyngeal space lesion is only after we get a radiology. So in radiology, how do we differentiate whether it's a pre-styloid or post-styloid? We have to look towards this yellow thing. This yellow thing is just the color yellow is just for representation. It is the parapharyngeal space fat. So a parapharyngeal space fat will look black, will be black on a CT scan and will be white in an MRI. So we have to see the displacement, how this parapharyngeal space fat is getting displaced to decide whether it's a pre-styloid tumor or a post-styloid tumor. So here there is a green colored tumor which is arising from the deep lobe of parotid. That means it is a pre-styloid tumor. So a pre-styloid tumor will always cause medial displacement of parapharyngeal space fat, and a post-styloid tumor that is arising from the carotid space will cause anterolateral displacement of the parapharyngeal space fat. So again, a pre-styloid tumor will cause medial displacement of parapharyngeal space fat, and a post-styloid tumor will cause anterolateral displacement of the parapharyngeal space fat. And also, since it is causing medial displacement of parapharyngeal space fat, it's pre-styloid, it will push the great vessels posteriorly. So a pre-styloid will cause medial displacement of parapharyngeal space fat and posterior lateral displacement of the great vessels. And just learn one thing, other one you will automatically remember, or just see this diagram to conceptualize it. But if you like, I usually try to learn this so that I can learn, so that I can automatically remember the other thing. Now, so after we get a patient who has signs and symptoms of parapharyngeal space, parapharyngeal mass, we get a CT MRI done. We look at the parapharyngeal space fat, we look at the great vessels displacement, and then we come to a diagnosis whether it is pre-styloid or post-styloid. Now, how to differentiate among the pre-styloid, among the various pathologies, how to differentiate? So I told you there are two contents you should remember in the pre-styloid. One is the deep lobe of parotid gland, other is minus lavy gland. So if there is a fat plane between the parotid and the tumor, that means a fat plane. If there is a fat plane present, that means it is not arising from the parotid. That means it is a minus lavy gland tumor or any lymphoid connective tissue tumor if the fat plane is present between the mass and the parotid. But if there is no fat plate between the masset and the parotid, it is arising from the deep lobe of parotid, that it is a deep lobe pleomorphic adenoma of the parotid. Then just remember these, there are two different kinds of growth pattern of the pre-styloid tumors. One is a dumbbell pattern where it goes anterior to the stylomandibular ligament, and which is a narrowest portion, so it presents as a dumbbell. But if it goes posterior to the stylomandibular ligament, it will present as a round body tumor. Why it is important? Because if I'll be telling you later that if you are going through a transoral approach to the pre-styloid parapharyngeal space tumors, these round tumors can be taken out by a transoral approach, but these dumbbell tumors cannot be taken out. So these growth patterns are important. They might ask you if these growth patterns are only for pre-styloid parapharyngeal space tumors. Now we have diagnosed on CT MRI how we can diagnose a pre-styloid versus post-styloid, and also different pathologies in a pre-styloid. Now coming to diagnosis of different pathologies in a post-styloid mass. So on imaging, suppose there is playing of carotid anteriorly and jugular vein posteriorly. That means that the tumors is arising from the vagus. If the carotid goes anteriorly and IJV goes posteriorly, that means there's a lesion in the vagus which is displaying these two vessels separately. So it can be a schwannoma or a neurofibroma, or it can be a paraganglioma, that is a glomus vagale. It can be a vagal glomus tumor, or a neuroma, or a neurofibroma, or a schwannoma. So to differentiate between these two, that is a paraganglioma of the vagus, that is a glomus vagale, versus schwannoma and neurofibroma, we have to get an MRI done. A paraganglioma on an MRI will be having a salt and pepper appearance. That is, there will be a flow void. Since paraganglioma is a highly vascular tumor, there will be flow voids we can see on MRI, which is called salt and pepper appearance. And if it is a schwannoma or a neurofibroma, there will be plain enhancement on MRI. No salt and pepper appearance can be seen in a schwannoma or neurofibroma. So if it is a vagal tumor, it can be a paraganglioma, schwannoma, or neurofibroma. If there is no splaying of carotid anteriorly and jugular vein posteriorly, then we can think about whether it is then we can think about other differential diagnosis of post-styloid tumors, that it could be a carotid body tumor or a sympathetic tumor. A carotid body tumor classically will cause displacement of the internal, and it will cause splaying of internal carotid and external carotid on angiography. On angiography, we can see that the external and internal carotid is split, and it is called as bayonet sign or Laird sign. If not, then the last DD is a sympathetic tumor, where we can see tumor rising from the sympathetic trunk and causes anteromedial displacement of the great vessels. So basically, you have to know whether it is a vagal tumor, which can be seen by splaying of carotid anteriorly and jugular vein posteriorly, or it is a carotid body tumor where there will be splaying of internal and external carotid on angiography, which is called as bayonet or Laird sign. So now we have a diagnosis whether of different pathologies. We know how all these different pathologies can be easily diagnosed just on the basis of imaging, and there is no need of doing a FNAC. Just on the basis of imaging, we know the pathologies. Now, if it is a schwannoma or a neurofibroma, how the management differs. A schwannoma is usually slow growing and it is enucleated, and since it is enucleated, we can preserve the nerve of origin. It can be easily shaved off. Schwannoma can be easily shaved off of the nerve, and the nerve of origin can be preserved. So a vagal schwannoma can be easily operated, preserving the vagus nerve. Whereas neurofibroma is intimately involved with the nerve. The nerve of origin has to be sacrificed. So radiotherapy is a good option than sacrificing the nerve. Now, quickly discussing about the paragangliomas of the head and neck. It's a topic closely associated with parapharyngeal space tumors. Therefore, I have brought this topic. So, head and neck paragangliomas, two we have already discussed. That is the carotid body tumor and glomus vagale. Other two are glomus jugular and glomus tympanicum. These are mostly found in the ear. They are not related to parapharyngeal space. Tumors related to parapharyngeal space are glomus vagale and carotid body tumor. So, paragangliomas can be adrenal, can be extra-adrenal. 80% of extra-adrenal paragangliomas are found in head and neck. So you can know how important this topic is. They are highly vascular tumors, and if we are going to resect these tumors, mostly the nerve has to be sacrificed. If we are resecting a glomus jugular or a glomus tympanicum or a glomus vagale, the nerve has to go. But in carotid body tumors also, if it is high-grade carotid tumor, it is difficult to resect. What is the most common paraganglioma in head and neck? It is a carotid body tumor, number one. It can be an exam question that the most common paraganglioma is a carotid body tumor, followed by glomus jugular, which arises from the 10th nerve or the Arnold nerve, followed by glomus tympanicum, which arises from the 9th nerve, also called as glossopharyngeal nerve or Jacobson's nerve. And least common is the glomus vagale, which again is a parapharyngeal space tumor, and it arises from the vagus, and it has the highest chances of malignancies as compared to other three tumors. Now, what are paragangliomas? These are cluster of cells that secrete vasopeptides, influence baro and chemoreceptors. Carotid body tumor, you should know, is most common in men, is more common in men. Glomus vagale is more common in women. For head and neck paragangliomas, you should remember a rule of 10, that is, everything is 10%. That is, 10% of the chances they are malignant, 10% of them are secretory or functional, 10% of them are multiple or bilateral, 10% of them are hereditary. Signs of the signs of function in a paraganglioma is that is patient can present with hypertension or flushing. But this is only 10% in head and neck. Only 10% of the head and neck paragangliomas are secretory or functional as compared to adrenal pheochromocytoma, in which most of them, around 80% of them, are functional. So we should obtain urinary catecholamines. How to diagnose? If patient is presenting with these functions, we should obtain urinary catecholamines. We should rule out genetic syndromes like MEN2A, MEN2B, or VHL. Now, this is an important question. This was my question in my AIMS entrance exam when I was giving AIMS the INISS entrance for head neck surgery. I got this question. So, most common mutation associated with head neck paragangliomas is a succinate dehydrogenase mutation. So if it is B, it is high likely to be malignant. If it is D, it is the most common mutation, and it is highly likely to be benign. And you should know that these head neck paragangliomas have maternal imprinting pattern. That is, it is inherited only from father. The disease is inherited only from father. Coming to some important points about carotid body tumor. This tumor is most common in males. It is the most common head and neck paraganglioma. It is located posterior medial to the carotid body, and it is subadventitial. The tumor arises beneath the adventitia, and the etiology is high altitude or hypoxia. Hypoxia causes a male living in high altitudes, a young male living in high altitude, that is hypoxic areas, it will cause hyperplasia of the chemoreceptors present in the carotid body. Hence, this carotid body tumor arises. The risk of malignancy is very low. I already told that glomus vagale has high risk of malignancy. In carotid body tumor, the risk of malignancy is only 6%. It presents as a firm rubbery mass, also called as potato tumor. It is compressible, and very important exam question that it presents to us with if this tumor is palpable in the neck, we can elicit Fontaine's sign, that is, horizontal mobility will be present, that is, it will move along with the carotid, but vertical mobility will not be present since it is fixed to the carotid. So the whole carotid moves, that's why horizontal mobility is present, but vertical mobility is absent. Already told, CT angio shows bionetral signs, that is playing of internal and external carotid. And one important exam question is white line of Gordon. What is white line of Gordon? That this, while we are operating this carotid body tumor, the dissection has to be subadventitial. That is, it should be below this white line. This white line marks the periadventitial plane in a carotid body tumor, and the dissection has to be subadventitial. That is below the adventitia. Blood supply of carotid body tumor is ascending pharyngeal artery. Innervation is the superior laryngeal nerve and the glossopharyngeal nerve. The branch of the glossopharyngeal nerve which supplies the carotid body is also called as nerve of Herring. Histological growth pattern is Zelebin growth pattern. That is, the cluster of cells are surrounded by vascular vessels. And if you see the pathology slide, the cluster of cells will be surrounded with vessels. And very important, the growth it is a slow growing tumor, highly slow growing tumor. The growth is only 0.83, less than 1 centimeter per year. Only 0.83 mm per year. And you should remember this fact. This can be exam question, that the growth is only 0.83 mm per year. And CT-MR angio is the most important pre-op investigation to see the bionetral sign. This is the Zelebin growth pattern as on the slides as already described. Now coming to a short 100% question for your exam, that is the Shamblin classification for carotid body tumors. There are 3 types. Shamblin originally described 3 types, which was modified by Luna Ortiz into 3A and 3B. Type 1. So what is type 1? Type 1 is the resectable tumor. It can be easily resected, and there's only minimal splaying. There's only minimal splaying to the blood vessels. It is only minimum attached. There's only minimum splaying. And in type 2, it is partially encasing the external carotid and the internal carotid. Whereas in type 3, it is completely encased. So this type 3 Shamblin is an unresectable tumor. Type 1 is easily resectable. Type 2 can be resectable. That I'll tell you later what we have to know whether it is resectable or not. Now there's a modification by Luna Otis in this type 3. They told that type 3A is same as type 3 Shamblin, that is encased, but if they give a new classification, type 3B. Type 3B means infiltration. Any size of the tumor which is infiltrating the great vessels also becomes unresectable. So this one or this one, if it is infiltrating, it becomes type 3B. So any size infiltrating is type 3B. Type 3A is completely encased as described originally as Shamblin. So what are the factors that go against resection of a carotid body tumor? If it is a high-riding carotid body tumor that is above C1 and C2 vertebrae, we should not touch it because there will be difficulty in getting a proximal control. If the size is more than 6 cm, it is difficult to resect. If it is adhered to surrounding structures, if it is Shamblin 3, it is difficult to resect. In Shamblin 2, it can be resected plus minus depending on the balloon occlusion test. We will do a balloon occlusion test. We will have a separate class. I'll be explaining you. In short, what is a balloon occlusion test? What you do, we inflate up, do angiography, insert a catheter in the internal carotid artery, inflate that catheter so that the blood flow to the brain from one side can be stopped, and we see within 10 minutes whether a patient is having any neurological signs or not. If not, that means the collateral supply from the other ICA is adequate, the collaterals in the circle of Willis are adequate, and patient's ICA can be resected. So in Shamblin 2, if a patient is able to tolerate the test, we can resect the tumor by resecting the ICA. If patient is not able to tolerate the test, we have to do a shunting between the a shunt has to be placed between ICA and ECA, and then only the tumor has to be resected after doing a shunt. Otherwise, it cannot be resected. In Shamblin 3, we have to do a subtotal resection if it is acceptable to the patient. That is a R1 or R2, leaving the cross disease behind, which can again grow. Second option is a radiotherapy. Third option is observation, since I already told that these tumors grow at a rate of 0.8 mm per year. So instead of going for a highly morbid surgery, we can go for observation. And fourth option is a EC-ICA bypass. That is creating a shunt between external carotid artery and the internal carotid branch of internal carotid, that is the middle cerebral artery. So basically, you should just remember that type 1 is resectable, type 3 is unresectable, type 2 can be resected if patient passes the balloon occlusion test. So this is a flowchart of how to approach a carotid body tumor. If it is a single carotid body tumor, it can be resected. If a patient is having a carotid body tumor as well as a vagal tumor, we should do surgery for a carotid body tumor and radiotherapy for the vagal or the jugular tumor. As I already told that a carotid body tumor can be resected without much morbidity if it is early Shamblin, but a vagal tumor, that is a paraganglioma of the vagus, it go for surgery. The vagus has to go. So cutting the vagus of the patient is a high morbidity. So mostly you should remember that a paraganglioma of the vagus, the preferred treatment of choice is radiotherapy, not surgery. Unlike a schwannoma of the vagus, a schwannoma can be easily dissected from the nerve. So a schwannoma can be operated, but a paraganglioma of the vagus, that is a glomus vagale, we should go for radiotherapy, then going for a upfront surgery. And also, if there is a bilateral carotid body tumor, the smaller one has to be resected and the larger one has to be given RT. We cannot resect bilateral carotid body tumors because it will cause a baroreflex failure. That is, patient will have, since they are baroreceptors located in the carotid body, patient will be having wide fluctuations in the BP and there will be tachycardia in response to stress. So bilateral carotid body tumors both should not be resected. A smaller one should be resected and the larger one should be given radiotherapy. So now coming to other paragangliomas which are not a part of parapharyngeal space, I have included them because they are paragangliomas. So number one is globus tympanicum, arising from the tympanic plexus, that is the promontory. Arises from the nerve, the ninth nerve, glossopharyngeal nerve, also called as Jacobson's nerve, and globus jugulaire, that is arising from the jugular bulb, which is associated with 10th nerve of vagus, also called as Arnold's nerve. This is the staging. This you can just go through quickly. Stage 1 is limited to promontory, 2 is reaching middle space, 3 extending into mastoid, 4th extending coming out into the external carotid canal. And this is the staging of the glomus jugulaire, that is tumor involving the jugular bulb, medulla, or mastoid. Type 2 is going into the internal aortic canal or may have intracranial canal extension. 3 is going up to the petrous apex, and 4 is going into the clivus or infratemporal fossa. Just go through this staging. I don't think this is important. So symptoms of glomus tympanicum or glomus jugulaire will be patient will be having pulsatitis, tinnitus, or hearing loss. Examination will show a bluish appearance behind the tympanic membrane, which blanches on pneumatic otoscopy. Since it's a vascular tumor, on doing a pneumatic or giving positive pressure from otoscope, there will be brown sign, that is, there will be blanching of this bluish appearance. And mainly glomus jugulaire tumors will be having a sign rising sun appearance when tumor arising from the floor of medial, that is a glomus jugulaire, when arising from the floor of medial can have a rising sun appearance. Now coming to glomus vagale, which is a paraganglioma, which can present as a parapharyngeal space tumor. It is more common in females. The most common site is the inferior nodose ganglion, that is, and it is 2 cm below jugular foramen. When it goes into the jugular foramen, it can present as a dumbbell tumor. 22% of patients can have intracranial extension at the time of diagnosis, and 50% have cranial deficits at the time of presentation. The staging of glomus vagale is when it is present just in the parapharyngeal space, that is in the inferior nodose ganglion, which is 2 cm below jugular foramen. When it is present there without evidence of jugular foramen invasion, it is called type 1. When it is causing jugular foramen invasion with no violation of the skull base, it is type 2. And when it is going deep into the jugular foramen and into the middle ear with extension to the skull base, presenting as a dumbbell tumor, it is type 3. So, what is the management of glomus vagale? The management of glomus vagale, according to me, is all first attempt should be a radiotherapy, because if it is very difficult to preserve the nerve in a paraganglioma, as I already told, 90% of the time the nerve will go. So, advantage of radiotherapy in a paraganglioma is that the dose required is less than 45 gray, and RT has better controls and lower incidence of morbidity. So, in a glomus vagale paraganglioma, our first option should be RT, since vagus is an important nerve which cannot be dissected out. When we should go, now this is an important question, when we should attempt surgery? Only when the nerve is preoperatively, there is a complete nerve palsy, or preoperatively there are compressive symptoms, patient is having compressive symptoms, then we should attempt surgery in a vagal paraganglioma. Now, so this was all about parapharyngeal space tumors. Quickly, we will be revising the workup. The workup includes imaging, laboratory test, and other tests. Imaging, there are 4 questions we should be looking into imaging. Already discussed whether the tumor is pre-styloid or post-styloid. How is the fat playing with the parotid gland? How is the relationship with the great vessels, and what are the soft tissue characteristics? So, what is the role of CT? CT can tell us differentiate between pre-styloid, post-styloid according to the displacement of the parapharyngeal space fat and the great vessels. It can tell us about deep lobe involvement. It can tell us whether there is a fat filling between the parotid and the mass, whether the parapharyngeal space tumor is arising from the deep lobe of parotid or is it a minor salivary gland tumor, whether there is any bone erosion in case of malignancy. But CT will tell only about limited soft tissue detail. It cannot differentiate between a paraganglioma and a schwannoma or a neurofibroma. MRI help us to differentiate between neurogenic tumors versus paraganglioma. As already discussed, paraganglioma will be having a salt and pepper appearance, that is, flow voids will be there since it's a highly vascular tumor, whereas neurogenic tumors like schwannoma or neurofibroma will only be having enhancement. And MR angiography help us to differentiate between neurogenic tumors versus vascular tumors like a carotid body tumor. So coming to laboratory studies, we should, if we are suspecting any functional paraganglioma, which is unlikely in head and neck because only 10% of them are functional, we can go for catecholamines, metanephrines, and urinary VMAs. And other tests like which can be done is a balloon occlusion test, which I already explained. It can be done in a Shamblin 2 or Shamblin 3 type carotid body tumor, where we are not sure whether patient will be able to tolerate resection of the ICA if required. Now, what about FNAC? Whether we should do a FNAC from a suspicious parapharyngeal space mass? The answer is it should be done only after imaging, and it should always be guided. And it is contraindicated if it is a highly vascular tumor like a carotid body tumor. FNAC is contraindicated in a carotid body tumor. If we go for FNAC in it, it will be a blunter. Patient can bleed heavily in the minor OT room where FNAC is being done. So it is contraindicated in carotid body. It should only be done after imaging and it should be a guided one. Now, coming to a very important topic, that is the approaches to parapharyngeal space tumors. It is a long question. It is a definite long question in MS ENT exit exam, and it will be definitely, if they are putting a question on parapharyngeal spaces, one of the options can be what will be your approach. So their approaches are transoral, transparotid, transcervical, mandibulotomy, and transmastoid or lateral skull base or fish approaches, because these lateral skull base approaches were given by fish. So number one is a transoral approach. Transoral approach is a little doubt whether this approach should be done or not. Scott Brown had initially mentioned that this approach is lamentable and should not be practiced in parapharyngeal space tumors. But with the recent advances of robotics and endoscope coming, the transoral approach is now again in limelight. The other standard approaches are transparotid, transcervical, mandibulotomy. These are the 90% of the approaches. 90% of the time these three approaches are taken. These 1 and number 5 you should be knowing, but these 3 are the 90% approaches that are commonly practiced. So coming to transoral approach should only be practiced if it is a pre-styloid tumor with a fat plane with a parotid, that is the pre-styloid that is arising from the minor sliding gland. It should not be arising from the deep lobe of parotid, otherwise it will be a mess. It should be a round with clear fat planes with the neurovascular plane, a round, a benign, a non-vascular, a circumscribed, a ball-like small tumor which is present in the pre-styloid compartment, which is less than 3 cm, not arising from the parotid. Then it can be easily approached through the oral cavity, dissected and taken out. So this is a transoral approach. Very limited indications. Just learn these indications. Second, now coming to transparotid approach. In this approach, we give a modified Player's incision. This is for a tumor arising in the deep lobe of parotid, a pre-styloid tumor arising in the deep lobe of parotid. We give a modified Player's incision. We do a superficial parotidectomy, preserve the cranial nerve 7, divide the stylomandibular ligament, and then go through these branches of the facial nerve and take out the deep lobe of parotid. Now, what is transcervical approach? A transcervical approach is for post-styloid tumors, or if it is a big deep lobe parotid tumor. A transcervical approach was for a pre-styloid deep lobe parotid tumor, but a transcervical approach is when the deep lobe of parotid tumor is very large and it cannot come out through the transparotid approach. Then we'll go for a transcervical approach, or if it is a post-styloid tumor. So in a transcervical approach, there is a 2 finger breadth. Incision is given 2 finger breadth below angle of mandible. Submandibular gland is retracted anteriorly, and stylomandibular ligament is divided. Now, and the tumor is taken out. Now, coming to the transmandibular approach. Transmandibular approach for a parapharyngeal space tumor is always done by a paramedial mandibulotomy. Number 1 point. Number 2, what are the indications? Indications are if it is a big tumor that is more than 5 cm, or if it is a malignant deep lobe tumor, or if it is a high vagal or a high vascular lesion, or if it is a superior parapharyngeal space lesion. So it gives the transmandibular or mandibular swing gives us advantage of a better exposure where distal control of carotid can be done at skull base. So these are the 5 indications of a transmandibular approach done through a paramedial mandibulotomy. Now, quickly going, what are the advantages of a paramedial mandibulotomy and then a median or a lateral mandibulotomy? In a paramedial mandibulotomy, it is done between the lateral incisor and the canine. So the roots of the lateral incisor and canine are diverging. So we can easily do a mandibulotomy without injuring the roots of the lateral incisor and canine, and so the teeth of the patient are not compromised. Unlike a median mandibulotomy, there is no division of the geniohyoid and genioglossus muscles in a paramedian mandibulotomy. So there is so these genioglossus and geniohyoid are intact, so that there is no tongue fallback. Since a paramedian mandibulotomy is done anterior to the mental foramen, there is no denervation or desvascularization of the skin of the chin of the teeth. And also, as compared to lateral mandibulotomy, in a paramedial mandibulotomy, it does not fall into the field of post-op radiation. If required, the lateral mandibulotomy falls in the field of post-op radiation. So the advantage of a paramedial mandibulotomy from a medial mandibulotomy is that the roots are diverging, so no teeth compromise. There's no injury to the genioglossus or geniohyoid as in a case of medial mandibulotomy. And compared to lateral mandibulotomy, the advantage is the field of radiation in lateral mandibulotomy, post-op radiation will also be given in the same field. And also, if you do a lateral mandibulotomy, there will be unequal pull of the muscles of mastication. So the union site can fracture again. When we do again plating after a mandibulotomy, it can fracture. So these are the types of mandibulotomy I was just trying to explain. The medial mandibulotomy occurs anterior to the mental foramen between the two central incisors, but the paramedial mandibulotomy occurs between the lateral incisor and the canine, so the roots are diverging. We can easily do the mandibulotomy without injuring the roots, whereas in medial mandibulotomy, the roots can be injured. Lateral mandibulotomy occurs posterior to mental foramen, so definitely the nerve will be compromised and there will be denervation of this area. Now coming to final approach is intratemporal fossa approach. This approach is done for high lesions which are near the skull base and are malignant lesions. So we have to go and do a lateral skull base approach. We have to approach the patient through this incision and do drilling in the skull base area to get out the tumor. So this approach is not commonly practiced. Most of the patients will be inoperable. So I'm not going into details of these approaches. You should just know which approach to use where. And finally, these are the recent advantages. There are two endoscopic approaches that have come up. Number one is a transnasal transpterygoid approach. In this approach, we go transnasal, we put an endoscope, then do a medial maxillectomy, then after doing a medial maxillectomy, open the posterior wall of the maxilla, see the pterygoid process, and there go through the pterygoid plates, and there we can reach upper parapharyngeal space. So this transnasal transpterygoid is good for upper parapharyngeal space tumors. That is endoscopic approach, which is transnasal transpterygoid, is good for upper parapharyngeal space tumors. And one more endoscopic approach is when we go transoral with the endoscope. That is good for lower parapharyngeal space tumors. So you can just imagine, if we go transorally, we can approach this lower parapharyngeal space. If you go transnasally, transpterygoid, we can approach this upper parapharyngeal space. And finally, already discussed transoral approach. That initial transoral approach which I showed was non-robotic. That is only like with tonsillectomy instruments, we are going into that area. But recently, this robotic transoral approach has come. And again, the indications are same that it should be a benign non-vascular, well-circumferenced region with a clear plane with neovascular bundle and a clear fat plane with parotid. That is, it should be a minus lavy gland tumor in the pre-styloid, which is not arising from the deep lobe of parotid, and should be a round tumor, not a dumbbell tumor, for a transoral robotic surgery. So I know it was an extensive talk, but you should listen to this talk again and again to learn all the pathologies in the parapharyngeal space, the approaches, the diagnosis, the radiological diagnosis, how to know whether it is pre-styloid, post-styloid. In pre-styloid, whether it is deep lobe of parotid gland or a minus lavy gland. In post-styloid, whether it is carotid body, glomus vagale. In glomus vagale, whether it is a paraganglioma or a schwannoma. In vagal tumor, whether it is a glomus vagale paraganglioma or a schwannoma or a neofibroma. How to find out these conditions and what are the management has been highlighted in this talk. So just go through it again and remember these are definite exam questions. Thank you.